Let me introduce our guest today, our speaker today, Dr. Loder. She is an obstetrician and gynecologist faculty here at the University of Michigan, who's also a family planning specialist. She has done her medical school at Pennsylvania State University College, and she does also a lot of research in reproductive justice, education, and postpartum contraception. So she'll be today discussing about contraceptive choices for women with underlying medical conditions. As we know, we always face these challenging patients where we want to, these are women who actually need more contraception because they are at high risk of maternal morbidity and mortality, but it is challenging to give them some of the choices. So she'll take us through how to approach such clients or such patients. So saying this, I'll give the floor to Dr. Loder. Thank you for giving this webinar today.
Yeah, thank you for having me. Can everyone hear me okay? I'm going to assume. Yeah, great. Okay. So today I'm going to talk about contraceptive options for women with chronic disease. And I selected a few chronic health conditions that I thought might be most pertinent. But I love feedback at the end of this to hear about what other chronic medical conditions you would want to hear about and in terms of choosing contraceptive options. So today I'm going to, because my interest is in reproductive justice and reproductive justice education, I'm going to highlight a reproductive justice approach to contraceptive counseling. And then I'm going to talk about prevalence, medical concerns, and contraceptive concerns with women with hypertension, headache disease, and pelvic inflammatory disease. So why do we care about contraception and chronic medical conditions? Well, one concern is that half of all pregnancies around the world are unplanned. And when we have unplanned pregnancies, we have unplanned deliveries some of the time. And there is high maternal morbidity and mortality in pregnancy. And so this is actually complications, maternal morbidity in Ethiopia specifically. So you can see that complications of abortion are fairly high. So we would want to prevent pregnancy. So we're preventing abortion and those complications. Hypertensive disorders are in the middle, and then this other direct maternal deaths is where the hypertension cardiovascular disease lies, and so that's why I've chosen some of those conditions to talk about today. So another consequence of unplanned pregnancy is that women may be taking medications that are teratogenic, so may be causing birth defects in their pregnancy. And so if a woman is taking medications for her hypertension or headache disease, it's important for her to know that those medications could affect a pregnancy if she becomes pregnant. Of course, we want to prevent any worsening of her medical condition, and pregnancy does have the risk of worsening, hypertension specifically, and may worsen headache disease. And then there's effects of the unplanned pregnancy in terms of what's going to happen to the fetus or neonate. And so there's a high risk of preterm birth and neonatal morbidity and mortality. So if we're preventing that pregnancy, then we can remove some of these concerns for our patient. Then we have to think about the risks of use of contraception, and there are some concerns, and we'll talk about them, that the contraceptive method itself may actually worsen the maternal medical condition, and those primarily relate to risk of stroke and cardiovascular disease, risk of DVT, especially with use of estrogen-containing methods. And so you'll see as I go through the talk that estrogen is the primary concern with these methods, and that's where things get a little tricky in deciding what method is best to use in women with these medical conditions. Okay. So what is reproductive justice? Reproductive justice is recognizing that there are political, social, and economic inequalities that exist in reproductive health care. And we know that historical injustices have happened all over the world, in the U.S. also, which I'm more familiar with the U.S. history, but we know that women are coerced to choose contraceptive methods, they're coerced to have sterilizations, they're coerced to become pregnant or carry their pregnancy, or even coerced into abortion. And what we ultimately want for all women is that they can fulfill their reproductive desires as they see fit. And that's our job, is to help women figure out what they want from their reproductive lifespan and help them meet those needs without our judgment or our opinion being involved in that. So we're there to help women figure out what is best for them. And so in counseling, one approach that this Oregon Foundation for Reproductive Health experimented with is they asked women different ways about what their plans were for their future pregnancies. And so they actually tried out a bunch of different questions that you could ask a woman and ask them how open-ended women felt these were. So the one key question that they came up with was, asking a woman, would you like to become pregnant in the next year? And women found that was a really great way to open up a conversation about their reproductive life planning. So were they planning to have a child, another child? Are they planning to avoid pregnancy? These are some just open-ended questions that you could ask a woman to figure out what those reproductive desires are, so then you can help make a plan with her. And this is recognized, the wording is specific. Would you like to become pregnant, and not are you planning to become pregnant? Recognizing that some women don't plan or don't want to plan, or planning may be a luxury of certain populations and not a luxury of others. And so some other important parts that come into contraceptive counseling are what is most important to the patient in her birth control method. And so there are different approaches to how you're going to offer different methods, but my approach is to ask those general questions in the beginning and then to ask the patient, what's most important to you? Do you want the most effective method? Do you want something that you can start today, or start after delivery, or start after your abortion? Is it important for you to have menses or to not have menses? How do you feel about the use of devices? And then how important is it that you can stop the method yourself, or that it's reversed right away? Or are you going to be somewhere where you can't have a physician or nurse or midwife remove your device, and that could be a problem. So I try to make sure that the patient knows that she is totally involved in telling me what's most important to her in her birth control method. And sometimes that brings up some myths about birth control and myths about devices that I can dispel before I just jump into, selling her on a particular birth control method, for example. Because we don't want to sell a patient on a LARC device. We want her to figure out if that's the right thing for her, and if that's what fits in with what's most important to her. So frequently I'll talk about these and say, based on what you've told me, that you don't want a pregnancy for 2 years, that you don't want to menstruate, and you've heard about devices and you're open to them, then I'm going to focus on these methods to talk about with you. While these other methods do exist, I'm going based on what you told me your preferences are. That way there's some shared decision making in the contraceptive choice. Okay. So when we talk about efficacy, we're talking about how often this method is going to fail, and that's something that's really important to patients, and it's also something that there are a lot of misconceptions about. So the Pearl Index is one way to quantify the number of failures per 1,000 women years of exposure. And so the implant, or edenogestrel implant, or Nexplanon, has a Pearl Index of 0.05. That's the most effective birth control method that we have. Sterilization is actually a little bit higher because sterilizations do fail. So that has a Pearl Index of 0.5. Combined hormonal contraception has a Pearl Index of 8, and then condoms 18. But you do have to consider that all of these methods depend on correct use, adherence, and that there are failure rates for typical use versus perfect use. And the Pearl Index reflects more of that perfect use. And you can imagine things like implants and sterilization are going to have more perfect use because it's hard for them to come out or fail compared to use of condoms or birth control, which you have to remember more frequently. Okay. So what are we going to do? We're going to weigh the risks and benefits of a contraceptive method, and the patient's desires, and her chronic medical conditions. And so when we're thinking about risks and benefits, it's easy for the statistics to get confusing and for patients to have misconceptions. And so many times what we're talking about with women is their absolute risk, how much their risk is being reduced, or how much their risk is being increased by the use of hormonal methods, or their relative risk. This is all based on our clinical trials. And so absolute risk is the percentage of people in a group who experience an event. So people at risk, and then the people who have the event. And frequently we're talking about venous thromboembolism or stroke when we're talking about estrogen methods, and we'll talk about their absolute risk for having a stroke or DVT when using a method. So an example, there is concern in the media in the US over the last decade about the use of third-generation combined hormonal contraceptives and risk of venous thromboembolism. So lots of commercials and lawyers talking to women about their increased risk when using a new method called YAS. But you have to consider that the absolute risk of having a thromboembolism for women was 30 women per 100,000 women years. So you can see that that risk is very, very low for the young women who are using this method. But we can also think about what is their risk reduction, how much is their risk reduced if they're exposed or unexposed. And so that depends on the method that they're using. So in this case, the absolute risk of having a VTE for a young woman might be 15 women per 100,000 years. So then the risk reduction is, you could say your risk is reduced by half or increased by 2, which sounds impressive. But when you consider that these numbers are either 15 or 30 in 100,000 woman years, that's not as significant. So it can get confusing, and it may be a question that comes up in counseling, and just important to say that it's a very rare event to begin with. And then relative risk is used to identify an association between an exposure and an outcome. Odds ratio is a similar way to discuss this risk, and that is usually determined from a case control study. So looking at those who've had exposures and determining their risk of or their odds of having an event like a venous thromboembolism. Okay. So we can see that if we told a woman her relative risk of having a venous thromboembolism on this third generation combined hormonal contraception was 2 times her previous risk, that might sway her against using it. But then if we use the absolute risk comparison, 30 per 100,000 women years versus 15 per 100,000 women years, a patient might not think that's as concerning. Okay. And then also to put it in context, we're using these oral contraceptives as a way to prevent pregnancy. And what is the risk of venous thromboembolism in pregnancy? That's 60 per 100,000 women years. So it's much safer to be using these combined hormonal contraceptions if it's preventing pregnancy, which is riskier in terms of this specific example. Okay. So I'm going to be using the WHO medical eligibility criteria in this talk, and there's a link below, and I'm sure you're very familiar with it. I'm just going to review the categories. So Category 1 means that there's no restriction for the use of that contraceptive method. Category 2 means that the advantages generally outweigh the theoretical or proven risks. Category 3 means the risks usually outweigh the advantages, and 4 means it's really unacceptable to be using that method in that particular health risk. Okay, so I'm going to go through a few cases talking about these 3 chronic medical conditions and what options we would want to consider or not consider offering our patients. So the first case is a 31-year-old G2P2 who presents to discuss contraception. She has had a delivery 6 months ago, and she tells us that she was diagnosed with gestational hypertension at 28 weeks, and then at 38 weeks her labor was induced because she was diagnosed with preeclampsia. At her postpartum visit, she was still using labetalol, 200 milligrams twice daily, and she's still using that today, 6 months postpartum, and her blood pressure is still elevated at 146/78. So at this point, 6 months postpartum, still using an antihypertensive, we consider that she has hypertension as a diagnosis. It's no longer hypertension associated with pregnancy. And so that's a consideration in what birth control method we're going to offer her today. Her blood pressure is elevated. She is on a medication. It seems to be working for her. And we don't expect her to have any vascular disease at this point because of this relatively new diagnosis. So we'll talk about what some options are for her. So just some background. Hypertension is when the blood pressure is elevated over 140 milligrams of mercury systolic or 90 diastolic. And it's the 7th cause of premature death in developing countries. And then 40% of adults over the age of 25 in Africa specifically have hypertension. So it is incredibly prevalent. And then in deaths that were not related to non-communicable diseases in Ethiopia, 15% were related to cardiovascular disease. So it's prevalent. It worsens cardiovascular disease and ultimately can cause and will cause death. And so we don't want to worsen the condition of hypertension by adding a contraceptive method that could worsen that medical condition. So what are the implications if a woman has hypertension and becomes pregnant? Well, the outcomes are concerning and may be poor depending on her control of her hypertension. So in so the risks are placental abruption, preterm birth, having a low birth weight, and then preeclampsia. And you can see that if someone has severe uncontrolled hypertension, that preterm birth and preeclampsia rates or percentages are very high. So we do want to incorporate that into our counseling. She has recently had a delivery, but she has a new diagnosis now of hypertension. So what does that mean if she does become pregnant? It means that pregnancy is a high-risk pregnancy. It means that she could have an abruption and she could risk her health or the fetus's health. it means she could have an early delivery, a small baby, and likely preeclampsia in the next pregnancy. So that it's very concerning for her to prevent that next pregnancy, or at least make sure that her blood pressure is well controlled so she doesn't get into those severe percentages there. Okay. So as I discussed before, we do have to consider, are the medications that she's taking for her high blood pressure, are those a concern if she were to become pregnant? And so the recommendations for first-line treatment are using methyl-dopa or labetalol because those have the safest safety profiles in pregnancy. Sorry about my typo. Second line is nifedipine or clonidine. And then third line is hydralazine, although we frequently here use that for acute hypertensive treatment. And it's considered first line in terms of an acute hypertensive episode. The major medications that are of concern are the ACE inhibitors and ARBs, which should be avoided due to congenital abnormalities, specifically in the renal system, and risk of oligohydramnios. Unfortunately, our patient is taking labetalol, so that would be safest if she were to become pregnant. But she's seeing us for birth control counseling, so I imagine that she does not plan to become pregnant soon. So, as I mentioned earlier, one of our major concerns is estradiol, and so estrogen-containing methods, because estrogen, is the hormone that can worsen these chronic medical conditions. So what does estradiol do? It increases angiotensinogen production from the liver and activates the RAS system. And it can actually increase systolic blood pressure and diastolic blood pressure, not insignificantly. And that increase is in all comers. We do know that in hypertensive individuals, that increase can be even more. And so we don't want to turn a well-controlled patient into a poorly controlled patient, or have to increase her medications, or add another medication because we gave her an estrogen-containing method. And so if a woman has hypertension and is taking combined hormonal contraception, her risk of having a heart attack increases 4 times. She has an increased risk of peripheral artery disease, and that actually has an 8 times risk. And then she has an increased risk of stroke. And there is some evidence that those higher dose estrogen containing methods were the big concern, but even a small estrogen dose can increase risk of stroke, and so that's why we're generally avoiding estrogen containing methods in women who have hypertension. So what are the recommendations? The recommendation is that you check a blood pressure before initiating an estrogen-containing method. If someone has just had a history of elevated blood pressure in her pregnancy, so if our patient was off her medication and had a normal blood pressure today, she could have a combined hormonal contraceptive method because it's category 2. However, that's not the case. She's still on a blood pressure medication. Her blood pressure is well controlled, but the WHO still considers that to be category 3 in terms of using combined hormonal contraception because of that risk of heart attack, stroke, peripheral artery disease, and then increased risk of premature death. And then if she were to have a blood pressure over 160 systolic or 100 diastolic, then the WHO considers that to be a category 4, so absolutely should not be used. And so we think about this, and I would explain this to a patient if she highly desired combined hormonal contraceptives, and try to discuss other methods with her. But ultimately, if she highly desired having a combined hormonal contraception, We thoroughly discussed the risks and benefits. There was absolutely no way she was going to choose another method. Then I may, if I were kind of forced or encouraged by the patient to give her a combined hormonal contraception, then the healthiest thing for her would be to choose the lowest dose method. And so there are pills that contain 20 micrograms of estrogen. So I would choose that, or the NuvaRing or vaginal ring, which has the lowest circulating dose of estrogen. But I would also reiterate that this is not the healthiest medication for her, but also realizing that this medication is still much healthier for her than that risk of becoming pregnant. And so you have to weigh those risks and benefits. And so if you were to offer that method after much discussion, it would benefit the patient to come back in a week or as soon as she can for a blood pressure assessment, because we want to make sure that estrogen is not increasing her blood pressure such that she needs to increase her dose of antihypertensive. Interestingly, Depo or medroxyprogesterone is also a concern in hypertension, and so the WHO considers it category 2 in a well-controlled patient, but in that patient who has poorly controlled hypertension or vascular disease, it's considered category 3. So how well a patient is controlled on her medication is incredibly important in choosing her contraceptive method. And then our preferred contraceptive methods for her would be progestin-only pills, implants, or the IUDs. And you'll see this coming up again and again, that the copper IUD is very frequently category 1 considered category 1 by the WHO because it's a non-hormonal method. And there just is some slightly increased risk with the progestins of having worsening of hypertension or some potential clot implications, and that's why they're category 1 for initiation and 2 for continuation of the method, but still considered that the benefits outweigh the risks in a hypertensive patient. Okay. So next I want to talk about a 25-year-old G1 who presents to initiate contraception. She's generally in good health, but she does report that she has headaches twice monthly. We ask her more about these headaches, and she says that she sees flashes of light just prior to the onset of the headache. The headache lasts for an hour. She usually has to lay in a dark room and sometimes needs to sleep in order to help them go away. She has one current partner. She has been tested for sexually transmitted diseases, and she has a 1-year-old and wants to wait a few years before attempting another pregnancy. So the headache prevalence in Ethiopia is similar to the U.S. So prevalence is 45% among throughout the country among men and women. Excuse me. And then the prevalence of migraine specifically is 17%. And so what is the difference? So there's headache, there's migraine without aura, and migraine with aura. So migraine specifically is a recurring headache, so it happens at least 5 times. It lasts 4 hours to 3 days. And then there needs to be 2 characteristics of it needs to be unilateral, pulsating, moderate to severe intensity, or aggravated by physical activity, so 2 of those, and then 1 of photophobia, phonophobia, or nausea and vomiting. So if she just has a severe headache that lasts for a few hours without any of those symptoms, it's a headache, a tension headache maybe, but you need all of those components in order to consider a migraine without aura. Now, migraine with aura gets a little more complicated. And this is all from the International headache disorder congregation. So migraine with aura, you need one of either a visual symptom, sensory symptom, or speech symptom. So the visual is flickering lights, spots, lines, or loss of vision, which is frequently described as like closing in from the outside in. The sensory symptom is pins and needles or numbness, or some speech disturbance that's fully reversible. And then the patient would have two of the following symptoms, either that she has these visual or sensory symptoms. One symptom lasts greater than 5 minutes, or there's a succession, she has all of them or two of them over 5 minutes, and that they last greater than 5 minutes and less than 60 minutes. And one of the key things in the history is that the aura usually precedes the headache. So usually she will have this flickering of lights and spots, I feel like, are the most common. So she'll have the flickering of lights, have the spots, and then within an hour she'll have that severe headache that can last up to 3 days. And so it is really important to delineate what kind of headache the patient is having, because that's really going to limit her contraceptive options in terms of increasing her risk because of the hormonal contraception. And so the history, of course, is always really important. And I've had some patients it's not as clear, they're not able to explain their symptoms as well. And then some patients have said, oh yeah, I never noticed, I do have those flashing of lights, and then the headache comes on. I never put that two and two together. A patient recently told me at Planned Parenthood. So there's some education. They might not have realized they're having a migraine, or even a migraine with an aura that can increase their health, down the line. So what is our concern with migraine and migraine with aura? The concern is the risk of stroke is increased in all migraineurs. And so having a migraine is an independent risk factor for having a stroke. And so that stroke risk, as we talked about before, that absolute risk is still 11 out of 100,000 for reproductive aged women. So that's still very low, but it is increasing to about twice that. And so we don't want to give any medications that are increasing a stroke risk in a very healthy population. So migraine without aura does have an increased relative risk, but migraine with aura seems to be the culprit, more of the culprit. And then we know that women under age 35 in general are healthy and have a very low risk of stroke, but over age 35 seems to be an additional risk factor for stroke. So like tobacco, it's something to consider in giving contraceptive method. Migraine and over 35, or tobacco and over 35. Another consideration is what medications she may be using for her migraines. And so we do know that topiramate is a cytochrome P450 inducer, so it can decrease the dose of combined hormonal contraceptions, progestin-only pills, and the implant. So really important to know what medications she might be using, because that is going to affect how you counsel her. Okay, so what are her options? Again, I'm going to start with combined hormonal contraception because it's the culprit. So if she does not have a migraine, we would be able to offer combined hormonal contraception. But this patient told us she sees flashing lights, they happen, and then her headache occurs. She has some photophobia. So we know that she has a migraine, and probably a migraine with aura. And so we're going to be concerned about her risk of stroke if we were to give her an estrogen-containing method. So in women who are under 35 who have a migraine without aura, The WHO considers initiation of a combined hormonal contraceptive to be Category 2, but continuation to be Category 3. And then, sorry about my typo here, migraine without aura and over 35, that the WHO generally considers using an estrogen-containing method to be not acceptable. So Category 3, there's still risk, and Category 4, unacceptable. So over 35 and a migraine, no estrogen. And then migraine with aura is considered to be Category 4, so again, not recommending estrogen. And this is a case, the risk of stroke, it's very rare that a patient would, hear that risk of stroke and still want to use an estrogen-containing method. But with a Category 4 for over 35 and migraine with aura, this is rarely something that I'm going to provide a prescription for a patient. And so, what are the options in terms of progestin methods? So progestin-only methods and Depo-Provera are Category 2 for migraine without aura, but they are Category 2 and 3 for migraine with aura, interestingly. And then the implant, next, the etonogestrel implant is similar. So without aura, you're okay for progestins, but with aura, still the risks may outweigh the benefits. So what can we offer her? The copper IUD is the safest method of all of these methods, besides barrier, of course. And then levonorgestrel IUD may be something we can offer her if she doesn't have an aura, but is still considered Category 3 in migraines with aura. And so the WHO medical eligibility criteria are, conservative, but they're meant to protect women and make sure that we're not giving methods that are going to increase, stroke risk, cardiovascular risk. And so given that this patient told us she wants to delay another pregnancy for 2 to 3 years, the copper IUD may be the best method for her and the safest method. So that's something that we could focus on with her. Next, I want to talk about a patient who has a history of PID. So she's a 19-year-old G0 who presents for contraceptive counseling. She's a college student and reports that she's had multiple sexual partners. And she does say she was hospitalized. She was told last year she had a pelvic infection. She's not quite sure what happened. She knows she got antibiotics, and she was told that this could affect her fertility. And so this history, frequently, I have young patients who aren't quite sure what their diagnosis was when they were hospitalized or got antibiotics. But this in particular is concerning for a history of pelvic inflammatory disease. And we just want to be careful that we're not giving her any method that may worsen that pelvic inflammatory disease. And we also want to make sure that we're practicing safely for her. So pelvic inflammatory disease is a polymicrobial infection of the upper genital tract, and usually is diagnosed by some actually pretty broad criteria, just uterine tenderness, cervical motion tenderness, adnexal tenderness, fever, abnormal discharge. And so our diagnostic criteria are very broad and probably lead to some over-treatment of pelvic inflammatory disease, recognizing that the treatment is safer than the consequences of having untreated pelvic inflammatory disease and resulting infertility, scar tissue, etc. So what are some options for contraceptive for a woman with a history of pelvic inflammatory disease? There are some studies that show that combined hormonal contraceptives may actually result in an increased risk of chlamydia infection. Once again, we don't know why, and that's something that we're looking into. But there also is evidence that estrogen-containing methods may reduce pelvic inflammatory disease. So the cervix, the lower genital tract, may have increased risk of becoming infected with chlamydia or gonorrhea, but the upper genital tract may not have that progressive infection because potentially there's some thickening of cervical mucus, which is preventing that polymicrobial infection from ascending. Once again, we don't know why, but this is the theory. In general, though, despite these theoretical risks, use of estrogen-containing methods is considered Category 1 for women with a history of pelvic inflammatory disease. Similarly, progestin-only pills, medroxyprogesterone, the etonogestrel implant, they're all Category 1 for women with a history of pelvic inflammatory disease. And then we wonder about the intrauterine devices. So with women with just a history of PID, we can place an IUD. It's considered Category 1 or 2. So we've considered she had an infection and we treated it, and so it is safe to place an IUD. However, if she has mucopurulent discharge, if she has uterine tenderness or adnexal tenderness, a fever, discharge, etc., and we think she has active PID, then we do not want to place an intrauterine device because that could delay her improvement with antibiotics, it could worsen her infection, etc. And so the WHO recommends that we want to screen appropriately, and only in very high-risk women, such as sex workers, having multiple episodes of PID, a known HIV infection potentially, or immunocompromise. Only in those women would we want to delay placing a device and maybe screening first, getting the results, and then placing the device. But in most women, we're going to offer screening at the time of placement and go ahead and place the device. And then if the results are positive, we don't have to remove the device. We can still treat with antibiotics as long as we think it's confined to the cervix. Of course, in a woman such as this patient who has had a history of multiple sex partners and a history of PID, we want to review that even if we are placing an IUD, barrier methods are what is going to prevent the sexually transmitted infections, and so it's important to use both. Okay, and then no, I think that's it for PID. Okay. So in conclusion, birth control is an important tool in reducing maternal morbidity. We want to make sure that we're helping a patient choose that birth control method in alignment with her reproductive life plan, and then we're discussing what's most important to her and making sure we're helping her make that decision based on her preferences and beliefs. That when a patient comes to us for birth control, it is an opportunity to screen for some medical conditions, to do some teaching, to do some medication education, and discuss the risks of pregnancy, the risks of the medication risk in terms of fetal exposure, and then also to discuss what are the long-term complications in using a contraceptive method. And then we also have to consider this absolute risk, relative risk in discussing risks with patients, and that ultimately the risks of stroke and clot are very low, but in some cases the WHO is still recommending against methods because it's unacceptable to increase their risk any more than it already is increased. So I'd be happy to take questions, and then I'd also really like to hear what other medical conditions are going to be most important to hear about in the future, because I I think that's going to help this talk moving forward. So if you want to let me know now or just let Leah know, that can help me craft either a follow-up talk or just adjust this talk in the future.
Thank you.
Yeah.
Okay.
Oh, thank you so much.
Maybe it's easier to see if
in
you
the
stop
chat.
sharing. So if you stop
Okay.
sharing, then we can open the so that they can. So if there are any questions, or as Dr. Loder now said, if you want to suggest other.
Or tell me that
areas.
there's a different practice that is different in Ethiopia compared to what I discussed, that I would be happy and interested to hear about that.
Those of you who are not sharing the video, it would be good so that you can give me a sign and I'll unmute you.
Maybe
Okay.
yeah.
Okay.
Okay, Farid,
and Farid.
Farid, and then Bahardar I'll give you. Okay, Farid, go ahead, you're unmute. You're unmute. I have unmuted you.
Thank you. Can you hear me now?
Yes, yes.
Okay, thank you. So my question is a kind of related to rather than the system of getting these patients. Now, for example, now we have not long ago that family planning service is a kind of service that is left to the low healthcare providers. It's very recent that OBGYNs are actively involved in providing family service. So it is fair to assume what should be the attitude of a neurologist, hematologist, or a cardiologist is towards family planning. We see multiple times that women who have a severe mitral stenosis comes with unplanned pregnancy. So how do you manage to get these patients to your service? Do the neurologist or hematologist or cardiologist provide the family planning counseling, or would they be referred to your clinic so that you can give them the detailed family planning, the options, the benefits, the risks? Probably that's where we have the limitations. Thank you.
Yeah, I think that is a huge limitation. So at the University of Michigan, I would say the cardiologists are the most proactive about actually doing the pregnancy risk discussion with a patient, more so than a contraceptive risk with a patient with, mitral stenosis, for example, or history of heart attack, etc. And so frequently they will discuss the risk of pregnancy, and then based on that risk, refer to our family planning clinic. But I think specifically with headache, I feel like a lot of internists, PAs, nurse practitioners aren't as aware of these medical eligibility criteria. And so when I'm seeing patients at Planned Parenthood, they tell me, well, I was on birth control pills. No one told me about this migraine issue. And so I feel like there still is education to do with these specialists who might not realize that headache and migraine specifically is such a risk factor for stroke with use of estrogen methods. So I think that's an area that can be improved upon. But yes, ultimately it's challenging. If they don't even know it's an issue, are they going to refer to us? So that's where I think outreach is going to be important.
So I think if there are further questions, you can email. But we'll have, I think, since today, I think you have covered, Dr. Loder has covered very important topics in hypertension, migraine headache, PID, which we face commonly, but also the other topics we raised. And if you feel there are other chronic conditions you'd like to see addressed, then we'll prepare a second session incorporating those medical conditions. Okay.
Great. Thank you.
Thank you very much. Have a good evening.
Yes.
And thank you so much.
Yeah. Thank you.